Welcome to the Radiographics Podcast. I'm Wende Gibbs. This week, my co-host Frederick and I are again dedicating our sections to the radiographics monographs. These collections, dedicated to one specialty, are great if you're a specialist wanting to keep up to date in your area, or if you're in training trying to learn about the most relevant topics you'll encounter when doing that rotation. Actually, this monograph is dedicated to emergency neuroradiology, so everyone will benefit from these topics, and especially if you take call. Dr. Frederick will be discussing traumatic neck and skull base injuries, extremely important, especially the vascular emergencies. I'll be discussing headache as a presentation in the emergency setting. Let's start with Dr. Frederick's summary.
Traumatic neck and skull base injuries. Patients with blunt and penetrating traumatic injuries to the skull base and soft tissues of the neck present to the emergency department every day. When encountered and not correctly diagnosed, these entities may result in severe morbidity or mortality. The radiologist plays a critical role in recognizing these key injuries, in which findings may often be subtle and the anatomy potentially challenging to identify. Vascular injury to the neck may result in dissection, occlusion, pseudoaneurysm formation, or frank extravasation resulting in stroke or death. Airway compromise may result from laryngotracheal injury. Injuries to the pharynx and esophagus may result in perforation. Injuries to the temporal bone may result in injury to the internal carotid artery or facial nerve, which would require immediate surgery or intervention to prevent paralysis. Imaging is vital for the modern evaluation of trauma, not only for diagnosing injury, but also for providing anatomic assessment and other pertinent information needed for planning appropriate therapy or surgery. This is especially true in the neck, where external manifestations of trauma and physical exam findings may not completely reveal the extent of the injury. Multi-detector CT has revolutionized the diagnosis of injury to the neck and skull base region, owing to the speed of acquisition and availability, and can accurately diagnose bone, soft tissue, and vascular injuries. The decision to perform CT angiography of the head and neck after initial imaging of the brain, neck, and face is based on the findings at the patient's initial presentation, results of the initial assessment, and clinical suspicion of vascular injury. Traumatic injury to the neck and skull base may be subdivided into non-penetrating or penetrating trauma. Non-penetrating trauma may result from a direct blow to the face and neck, resulting in fracture of the face, skull base, or cervical spine. A direct blow to the central aspect of the anterior neck may result in fracture of the laryngeal osteocartilaginous structures or injury to the laryngeal soft tissues or pharynx. Injury to the vascular structures may result in direct arterial injury, venous injury, or hematoma formation, which may impinge on the airway. Penetrating trauma to the neck accounts for less than 1% of admissions to the ED. Penetrating trauma to the head and neck does not respect the normal fat planes, and determining the path of the instrument or projectile necessitates evaluating all structures along its path. Emergent injuries to the neck that extend beyond the deep cervical fascia can generally be subdivided as involving the central neck, resulting in laryngotracheal and/or pharyngoesophageal injury, and the lateral neck with potential for vascular injury. Let's discuss vascular injury. Vascular injury to the vessels in the neck and skull base may range from minor injury requiring no intervention to catastrophic vascular rupture requiring emergent surgical or endovascular intervention. For many ED providers, penetrating trauma to the neck automatically warrants CT angiography, as long as the patient is hemodynamically stable, to further determine the extent and tract of the offending object to assess for vascular injury or active hemorrhage. Fracture of the cervical spine may result in injury to the vertebral artery as it travels within the transverse foramen within the lateral mass of the cervical vertebral bodies. If there is a cervical fracture, it is important to note if the fracture plane enters the transverse foramen or is close to the vertebral arteries. Fractures of the C1 ring or the C2 vertebral body may apply abnormal stretching to the vertebral artery, which may also result in injury. The aortic arch and great vessels should be individually inspected and should demonstrate a fat plane encircling the vessel. The vessel should be smooth and round in appearance. Abrupt changes in vessel caliber, contour, wall thickening, and/or irregularity, or loss of the fat plane around the vessels may represent underlying vascular injury. The vessels of the external carotid artery should also be inspected, as pseudoaneurysm formation or frank extravasation of contrast material may be present. The types of vascular injury include luminal narrowing owing to intimal or subintimal injury, vascular dissection with the presence of an intimal flap or intramural thrombosis, and frank vessel rupture. With traumatic dissection, thrombosis of the false lumen may cause tapering of the true lumen and occlusion. Rupture of the vessel may result in formation of a pseudoaneurysm contained by the adventitia along the outer aspect of the vessel. Transection of the vessel may result in frank extravasation of contrast material, which may or may not be contained by surrounding hematoma. Let's cover laryngotracheal injury. Such injuries result from blunt or penetrating trauma to the central neck. Blunt laryngotracheal injury is found most commonly in patients involved in motor vehicle collisions, but it can also manifest from hanging, strangulation, or direct blow to the central neck. Evaluation for laryngeal patency is the most important initial step in cases of suspected or known laryngeal injury. Laryngeal compromise may be secondary to edema, extrinsic compression due to hematoma, or intramural hematoma. In the setting of supraglottic edema, CT is especially useful and may be the only method with which to evaluate the airway, as the passage of a scope for direct visualization may be limited. A direct blow to the larynx and supporting structures may result in fracture to the hyoid bone or cartilaginous injury, in addition to laryngeal compromise. A complete imaging evaluation should include inspection with both bone and soft tissue window settings in all three planes. Fractures of the thyroid cartilage are most commonly vertical fractures of the thyroid laminae or through its midline aspect. Injury at the level of the cricoarytenoid joint, located along the superior posterior aspect of the cricoid cartilage, may result in subluxation or dislocation of the arytenoid cartilage, best seen on parasagittal images. Findings on axial images may show loss of symmetry of the bilateral cricoarytenoid joints, with asymmetric appearance of the true vocal folds. The cricoid cartilage, the only complete cartilaginous ring within the larynx, maintains patency of the larynx. As with most complete rings, fracture of the cricoid cartilage typically occurs in more than one place, and the lumen of the larynx may subsequently collapse. On CT, the mucosal surface is normally thin and cannot be well visualized. Any soft tissue thickening at the level of the cricoid cartilage within the subglottic larynx should therefore be considered abnormal. The type of injury to the larynx with the worst outcome is laryngotracheal separation. This typically occurs at the cricothyroid membrane and may be partial or complete. Significant subcutaneous emphysema is located around the larynx and visceral space on images, and it is usually fatal at the time of occurrence unless an artificial airway is established at the time of injury. They are generally associated with other injuries. Now let's review pharyngoesophageal injury, which almost always occurs due to penetrating trauma. The presence of subcutaneous air within the deep spaces of the neck should raise the possibility of pharyngoesophageal injury in addition to laryngeal injury. The trajectory of the offending instrument should be determined in an attempt to project the site of perforation. The presence of mural or extrinsic hematoma and loss of fat planes surrounding the pharynx may also guide the determination of the site of the perforation. Suspected perforation warrants a swallow study with oral contrast if endoscopy has not been performed. Moving on to temporal bone and skull base fractures. Most fractures of the petrous temporal bone are the result of blunt trauma and are not treated in the emergency setting. However, facial nerve injury in the setting of temporal bone fracture may result in facial nerve paralysis and should prompt further evaluation with temporal bone CT. Additional indications for temporal bone CT include sudden conductive or sensory neural hearing loss, CSF leak, suspicion of an acute vascular injury, or preparation for immediate or potential surgical intervention. Otic capsule sparing fractures, also called longitudinal fractures, are oriented parallel to the long axis of the petrous ridge, from the external auditory canal toward the foramen ovale, anterior to the otic capsule. Otic capsule violating fractures, also called transverse fractures, are oriented perpendicular to the long axis of the petrous ridge, from the foramen magnum toward the foramen spinosum, and often involve the internal auditory canal. Both fracture types may involve the facial canal and can result in facial nerve paralysis. If there is a bone fragment extending into the intratemporal facial canal in the setting of temporal bone fracture, facial nerve exploration at the site of fracture is required to prevent permanent disability. Fractures of the central skull base may extend to the foramen lacerum or carotid canals, resulting in carotid vascular injury. Fractures extending to the cavernous sinus may also result in carotid injury with carotid cavernous fistula or cavernous sinus thrombosis. Properly identifying and reporting fractures involving the anterior skull base is also critical, as these fractures may result in CSF leak causing intracranial hypotension and may become a route for the spread of infection. Such injuries may be repaired in the acute setting. In addition, notifying the clinical team of an anterior skull base fracture involving the cribriform plate and our fovea ethmoidalis may help prevent inadvertent intracranial penetration by support tubes. This is a key area where the radiologist can provide value. Let's recap a few key points. If there is a cervical fracture, it is important to assess if the fracture plane enters the transverse foramen or is close to the vertebral arteries. Fractures of the C1 ring or the C2 vertebral body may apply abnormal stretching to the vertebral artery, which may also result in injury. The cricoid cartilage, the only complete cartilaginous ring within the larynx, maintains patency of the larynx. Fracture of the cricoid cartilage typically occurs in more than one place, and the lumen of the larynx may subsequently collapse. Laryngotracheal separation is the worst type of laryngeal injury and is usually fatal at the time of occurrence unless an artificial airway is quickly established. If there is a bone fragment extending into the intratemporal facial canal in the setting of temporal bone fracture, facial nerve exploration at the site of fracture is required to prevent permanent disability. A complete and immediate facial paralysis also warrants immediate exploration of the intratemporal facial nerve at the site of injury.
Great. Those skull base and neck emergencies are always hard and induce a lot of stress because it's vital that you don't miss anything. The topic of headache seems more mundane. I actually chose this paper because I see it as an indication for my studies so commonly, and I wanted to make sure that I'm up to date on all the possible things that I might see. Headache is one of the most common patient concerns in the emergency department, and approximately 2 to 4% of all patients who present to the ER report symptoms of headache that are unrelated to trauma. I actually would have thought it was a lot more than that. Appropriate selection of patients who require diagnostic workup is important. According to the Choosing Wisely initiative of the American Board of Internal Medicine, no imaging should be performed in patients with an uncomplicated headache. The American Headache Society similarly does not recommend neuroimaging studies in patients with stable headaches that meet the criteria for migraine. The American College of Radiology developed evidence-based guidelines, the ACR appropriateness criteria, to assist providers in making imaging decisions for patients who present with headache. Indications for neuroimaging are strongly based on the patient's clinical history and a detailed physical exam. Studies have shown that several clinical signs, symptoms, and types of headache are associated with increased likelihood of the patient having a serious intracranial abnormality. These include abnormal findings at neurologic exam, a cluster-type headache, the patient seeing an aura or vomiting, a headache that the clinician cannot define as being caused by a common primary headache disorder, and a headache aggravated by exertion or Valsalva. Among these findings, the highest association with serious intracranial abnormality was found to be with the presence of any abnormal finding at neurologic exam. Other helpful clinical information includes pain radiating to the face or neck, Horner syndrome, cranial nerve palsies, systemic symptoms such as fever or weight loss, immunosuppression, known malignancy or HIV infection, pregnancy, vision loss, or pulsatile tinnitus. Special consideration is given to the thunderclap headache, which is a severe headache for which the patient reports a pain score of at least 7 on a 0 to 10 pain scale, and during which the pain peaks within 60 seconds of onset. Thunderclap headaches have the highest imaging yield in the ED. A large Norwegian study showed subarachnoid hemorrhage in about 17% of patients who presented with acute severe headache in the ED. However, the percentage was dramatically higher, almost 50%, in patients who presented with a thunderclap headache or reported having experienced the worst headache of their life. The location and type of pain are not specific. It may be a single headache or may recur over a few days. Neurovascular disorders, including ruptured aneurysm or reversible cerebral vasoconstriction syndrome, RCVS, are the most common causes of thunderclap headaches. Less commonly, intracranial hypertension or hypotension, infection, cervical artery dissection, cerebral venous thrombosis, or pituitary apoplexy may also manifest with a thunderclap headache. Pregnancy requires that special emphasis be given to multiple precipitating factors that are unique to the peri- and postpartum periods. The most common causes of headache during these periods are posterior reversible encephalopathy syndrome or PRES, sinus cerebral venous thrombosis, postepidural headache, and Sheehan syndrome. Well, let's start with hemorrhage. The most common cause of non-traumatic subarachnoid hemorrhage is ruptured aneurysm. The accuracy of CT for reliable detection of subarachnoid hemorrhage is 98 to 99%. CT angiography has specificity rates of 90 to 94% for aneurysms smaller than 3 mm and up to 100% for aneurysms larger than 4 mm. MR angiography is used most in non-emergency settings. Three-dimensional time-of-flight MR angiography is the most widely used technique and provides good spatial resolution. However, it can at times be of limited value because of its susceptibility to motion artifact and the intrinsic T1 hyperintensity of methemoglobin-containing hematomas, which could appear on source images. In those cases, contrast-enhanced MRA, which has higher sensitivity approaching that of CTA, may be preferred. Vessel wall MRI is an emerging technique for evaluating intracranial vascular disease. Although it's not commonly used in the ED, vessel wall MRI may help in determining which aneurysm is ruptured in patients with acute subarachnoid hemorrhage and known multiple aneurysms. In these cases, to decide whether a surgical intervention is necessary, vessel wall MRI is performed to investigate inflammation and/or enhancement of the aneurysm wall. In autopsy studies, inflammatory changes such as macrophage and leukocyte invasion, which may manifest as circumferential aneurysm wall enhancement, were encountered more commonly in the vessel walls of ruptured aneurysms than in unruptured aneurysms. Cerebral arteries are the third most common site of infected mycotic aneurysms, after those of the aorta and peripheral arteries. Infectious arteritis destroys the vessel wall with resultant contained rupture and pseudoaneurysm formation. Although most cases are asymptomatic, patients may present with a headache, seizure, or focal neurologic deficit. Anterior circulation is more commonly involved than posterior. They tend to be located peripherally, segment 2 and beyond, and are fusiform in appearance. The A2 segment courses superiorly along the genu of the corpus callosum. The M2 segment refers to the Sylvian segment of the middle cerebral artery after it trifurcates into an anterior division, posterior division, and the anterior temporal artery. In up to 15% of patients with subarachnoid hemorrhage, no source of bleeding can be found. 2/3 of these cases are related to perimesencephalic subarachnoid hemorrhage. Non-aneurysmal perimesencephalic subarachnoid hemorrhage is characterized by the presence of subarachnoid blood immediately anterior to the midbrain and pons, most commonly in the intrapeduncular and prepontine cisterns. Hemorrhage may extend into the ambient or quadrigeminal plate cisterns, or to the basal part of the Sylvian fissures. In rare cases, there is further extension along the lateral Sylvian fissures or the posterior part of the interhemispheric valgus. This pattern at non-enhanced CT is reliable only within the first 3 days after onset of symptoms because the blood redistributes. Angiographic studies are normal. Recognition of this type of subarachnoid hemorrhage is important given its excellent prognosis, as there's no rebleeding, vasospasm, or hydrocephalus. The incidence of intracerebral or parenchymal hemorrhage is approximately 25 per 100,000 person years, with a mortality rate of 40% at 1 month after presentation. Headache is more common in patients presenting with intracerebral hemorrhage than those with subarachnoid hemorrhage or stroke. Additional clinical manifestations of parenchymal hemorrhage include focal neurologic deficits that develop within minutes to hours. This gradual occurrence of functional loss is uncommon in patients with stroke or acute subarachnoid hemorrhage. Vomiting is also more common with parenchymal hemorrhage than in stroke or subarachnoid hemorrhage. Hypertension is the most common cause of non-traumatic parenchymal hemorrhage in elderly patients, and those are the ones we see most with parenchymal hemorrhage. Hypertensive cerebral microangiopathy affects the small, deep perforating arteries that supply the basal ganglia and deep white matter. The most commonly affected sites are the basal ganglia, thalamus, pons, and cerebellum. Cerebral amyloid angiopathy is the major differential for lobar hemorrhage or peripheral microhemorrhages in these elderly patients. This entity is characterized by amyloid deposition in the small to medium-sized cortical and leptomeningeal vessel walls, which leads to fibrinoid necrosis and vascular fragility that appear at imaging as multiple microbleeds in lobar distribution. Less commonly, cerebral amyloid angiopathy is associated with cerebellar involvement. The lobar distribution tends to favor the posterior cortical regions, particularly the occipital lobe. As in hypertensive microbleeds, cerebral amyloid angiopathy microbleeds have been linked to increased risk of parenchymal hemorrhage. Gradient echo, or even better, susceptibility-weighted MRI are the best methods for evaluation of microhemorrhages. Let's move on to vascular abnormalities. Reversible cerebral vasoconstriction syndrome, or RCVS, is not a single disease, but rather is the end result of multiple abnormal processes that cause reversible vasoconstriction in the cerebral vasculature. The pathophysiology is still not clearly understood, but disturbance in the cerebral vascular tone appears to be the final common pathway. RCVS presents with a thunderclap headache, and its symptoms mimic those of aneurysmal subarachnoid hemorrhage. The headache usually starts posteriorly and may become diffuse over time. It's often triggered by exertion, valsalva, emotion, postpartum state, or vasoactive substances such as illicit drugs. Imaging is important to confirm the diagnosis of RCVS, to exclude other causes such as aneurysmal subarachnoid hemorrhage or cerebral vasculitis, and to monitor potential complications. Non-enhanced CT of the brain is the initial modality for evaluation and shows intracranial hemorrhage, cerebral edema, and in some cases infarcts. However, the initial CT appears normal in most patients. Various patterns of intracranial hemorrhage, convexity subarachnoid hemorrhage, intracranial hemorrhage, and or subdural hemorrhage can be seen. The key imaging feature of RCVS is segmental arterial vasoconstriction characterized as a string of beads, with alternating areas of arterial stenosis and dilatation. Angiographic studies can be normal during the first week after clinical onset. This is likely related to the centripetal progression of cerebral vasoconstriction. The small peripheral arterioles are affected first, and the medium and large cerebral arteries may not yet show vasoconstriction at the time of initial imaging. Segmental arterial vasoconstriction can lead to ischemic and hemorrhagic infarcts that may cause permanent disability and in severe cases death. Infarcts often are seen in the arterial border zones. By definition, and also included in the diagnostic criteria, the cerebrovascular abnormalities are transient and resolve within 3 months. How about cerebral venous thrombosis? Headache is the most frequent and often the first symptom of venous thrombosis. However, it's associated with other symptoms such as papilledema, focal deficits, seizures, altered consciousness, or cranial nerve palsies as well. Headache type is nonspecific and can be thunderclap, acute, or progressive. The superior sagittal sinus is involved most commonly. Cortical venous involvement is seen in 6%, however it's likely to be overlooked when there's accompanying dural venous involvement. Parenchymal imaging abnormalities reflect increased venous pressure, vasogenic or cytotoxic edema, or parenchymal hemorrhages in 1/3 of cases. Substantially increased venous pressure may impede arterial perfusion and cell death may occur. The initial imaging evaluation starts with non-contrast CT. The thrombosis may appear to be hyperdense, but this finding is present only in about 20 to 25% of cases. CT or MR venogram is the next step. How about cervical artery dissection? I always think this is a scary one. You can't miss this. Spontaneous dissections occur in patients with underlying arteriopathy and can be triggered by minor activities such as coughing, vomiting, or cervical manipulation. Headache is the earliest symptom and is reported in about 70% of patients with spontaneous internal carotid artery dissection and 70% of those with spontaneous vertebral artery dissection. Cervical dissection is most commonly seen distal to the carotid bulb, extending toward the skull base and terminating before the petrous segment. Intracranial dissection, most common in the supraclinoid segment. Vertebral artery dissections are often seen in the V2 and V3 segments. The accuracy of MRA and CTA for diagnosis of dissection is relatively similar between the carotid and vertebral arteries, with about 80 to 99% sensitivity and specificity. Angiographic findings of arterial dissection include an intimal flap, elongated tapered stenosis or occlusion, and a dissecting aneurysm or pseudoaneurysm. Okay, I'm going to stop there. There's so much more in this very useful article, but I'm out of time. Who knew there was so much to headache? Make sure you take a look at this on the Radiographics website. Well, thank you for joining us. Keep an eye out for the body imaging monograph coming out this month. And make sure you register for RSNA. Can't wait to see everyone there.